The words, "I have a terrific pain in the back of my head," were the last words of the American President Franklin D. Roosevelt. Had he lived today, his cause of death would have been different. You see, President Roosevelt's blood pressure had increased over his presidency, but at the time there were no medications to treat his high blood pressure. In fact, when President Roosevelt was photographed here in Yalta at the end of World War II with Winston Churchill on his right and Joseph Stalin on his left, his blood pressure was measured at 235 over 140 millimeters of mercury. Shown here is one of the last known pictures of President Roosevelt taken the day before his death. His blood pressure at this time exceeded 300 over 190 millimeters of mercury. This American president suffered from both heart failure as well as a hemorrhagic stroke that finally took his life. Hello, I am Dr. Matthew Nelson, an Idaho invasive cardiologist. The purpose of this video is to ensure clinicians, allied health staff, and community health screeners know how to accurately measure an individual's blood pressure. Accurate blood pressure measurement is an essential skill and vital to the well-being of our patients. Hypertension is known as the silent killer because there are often no warning symptoms or signs. In 2019, 30.6% of Idaho adults reported being told by a health professional that they had high blood pressure. The impact of undiagnosed and untreated high blood pressure is significant. In 2020, hypertension accounted for more deaths from cardiovascular disease than any other modifiable risk factor in the United States. Hypertension is second only to diabetes in causing end-stage kidney disease. In one of the largest scientific studies on the effects of high blood pressure, it was shown for every 20 millimeter of mercury increase in systolic blood pressure, heart disease and vascular disease risk doubles. In Idaho, heart disease and stroke are the first and seventh leading causes of death, respectively, in 2021. What is worrisome is only 55% of women and 49% of men have their blood pressure under control. In addition, it's estimated that a 45-year-old person without high blood pressure has about a 90% chance of developing high blood pressure in their lifetime, regardless of their gender or ethnicity. I promise you will learn something from this video no matter how long you've been checking blood pressure. This video will cover the blood pressure devices, factors that could result in an inadequate blood pressure measurement, the process for accurately measuring blood pressure, common troubleshooting, and final tips and tricks for ensuring proper diagnoses. With accurate blood pressure measurement, proper diagnoses, effective treatment, and evidence-based interventions, we can improve hypertension control and save lives. What is high blood pressure? Here is what defines normal and abnormal blood pressure. Normal is less than 120 over 80. Elevated is considered to be 120 to 129 over less than 80. Stage 1 high blood pressure is 130 to 139 over 80 to 89. Stage 2 is greater than 140 over 90. The measurement of blood pressure is one of the most frequently performed medical tests. However, some blood pressure readings by healthcare providers are incorrect. We'd like to show you an example of measuring blood pressure. See if you can identify some of the things that are done wrong.
Go ahead and have a seat right here and we'll get your blood pressure.
Okay, thanks. Can I use the bathroom beforehand?
Let's get your blood pressure first. Any fun plans this week?
I'm hoping to get out of the heat and into the mountains, maybe for some camping.
Oh, nice. You like to camp at campsites or just find your own place?
Both, probably more campsites. Take the tent and do some hiking.
That's fun. Camp close to water.
Yeah, definitely. For
Do some water
paddling,
activities.
yes,
Nice.
for sure.
Okay, great. Blood pressure is 120 over 80.
As I review some of the things that were done incorrectly, see how many you identified. and if you identified others. 1. Blood pressure should be taken with an empty bladder. 2. Blood pressure should be measured after 5 minutes of sitting. 3. The provider should leave the room when blood pressure is checked. This is only applicable if another healthcare professional in the room is taking the measurement. 4. The cuff should be sized to the arm. 5. Feet should be on the floor with the legs not crossed. 6. Blood pressure should be taken without making conversation. 7. The blood pressure cuff should be placed directly on the skin. What are some of the other errors made with blood pressure measurement? First, some errors involve equipment. There are 3 devices used for blood pressure measurement. The first are aneroid manometers or manual cuffs. The second are mercury manometers. The third are oscillometric devices, which are the typical automatic devices used in offices and for home purchase. The manual blood pressure cuff system must be calibrated against a mercury device every 3 to 6 months to confirm accuracy. The fact that the needle is at 0 when the cuff is deflated is not an indication the instrument is functioning properly. Mercury manometers may not produce accurate readings if the mercury is dirty, if the mercury is bouncing excessively on deflation, or if the mercury is above or below 0 when the system is deflated. Oscillometric devices use mathematical algorithms of pulse waves as the cuff deflates. Oscillometric devices used at home should be listed as validated devices on validatebp.org and periodically validated and calibrated in the clinic setting. A medical provider must be aware that irregular pulses, as seen in atrial fibrillation or from frequent ventricular or atrial ectopy, can lead to inaccurate readings. In patients with heart rates below 50 beats per minute, there may be too few beats needed for the machine to determine an accurate blood pressure. The medical provider may also be a source of error. In addition, if a manual cuff and stethoscope are used, hearing loss, poor eyesight, environmental noise, and hearing fatigue may lead to inaccurate measures. Screeners should be aware of measurement bias. This means the provider will underread or overread the blood pressure based on impressions about the patient. For example, overreading can occur in the case of overweight or elderly patients. Another provider error comes in the preference of the screener for reporting certain numbers, especially 0 and 2. One might find certain screeners' recordings all end in the same number, such as 120/80, 130/90, or 160/110. Another form of bias is called cut point bias. This is an unconscious tendency to underread the blood pressure so as not to have to tell the patient their blood pressure is elevated. Previous reading bias is the tendency to record a reading similar to those obtained in the past, either by asking the patient, "What is your usual blood pressure?" or by referring to the chart to determine the blood pressure on the patient's last visit. Patient factors may also be a source of error if the patient is not properly positioned. The patient should be seated in a relaxed, comfortable, but not a slouched position. The individual's feet should be flat on the floor and their back fully supported. One study has shown that sitting on an exam table without back support can cause the blood pressure to be as much as 10 millimeters of mercury higher than it really is. The blood pressure cuff should never be placed over clothing. When the cuff is placed directly on the individual's skin, it should be possible to place 2 fingers under the sleeve with no difficulty. If this is not possible, the sleeve is too tight and will create an additional source of pressure on the artery that can distort the reading. The individual's arm should be slightly flexed with palm up, and the whole forearm supported on a smooth, flat surface with the brachial pulse at heart level. If the brachial pulse is below the level of the heart, the reading will be higher than the true blood pressure. If the brachial pulse is above heart level, the reading will be lower than the actual blood pressure. The patient should not be leaning on the arm, as this can cause increased diastolic pressure. Factors other than patient position can also lead to errors in measurement. Patients should not smoke for at least 30 minutes before the measurement is taken, as nicotine can temporarily elevate blood pressure. Caffeine should also be avoided within 30 minutes of blood pressure measurement, as it can also increase blood pressure. When measuring blood pressure in a new patient, blood pressure should be measured in both arms, as several medical conditions, such as peripheral arterial disease, can cause blood pressure to be different between arms. Now we're going to demonstrate the proper technique to measure in-office blood pressure.
Go ahead and have a seat right here. Do you need to use the restroom before we start?
No thanks.
All right, so I'm just gonna let you sit for about 5 minutes to relax, and then I'll be back to get your blood pressure. Thanks. Okay, let's get that blood pressure in. Okay, I'm gonna get this started and step out while it takes the measurement, and I will be right back. Okay, and then so that we can get an average, I'm going to take it a second time. That was 96/62. I'll be right back. Okay, 97/62.
Let's review proper blood pressure measurement. Properly prepare the patient. Position the patient in a chair with feet flat on the floor and back supported. The patient should be allowed to sit quietly for at least 5 minutes before measuring the pressure. The patient should avoid caffeine, exercise, and smoking at least 30 minutes before measurement. The patient should have an empty bladder. The patient should not talk during the measurement. Remove clothing from the individual's arm and make sure the arm is fully supported on the table with the brachial pulse at heart level. If possible, the provider should leave the room if an automatic device is used. Select proper size cuff for the size of the patient's arm. Cuff size cannot be determined by the fact that the cuff will fit around the arm without coming off during inflation. The screener must ensure the inflatable bladder inside the cuff encircles 80% of the arm in adults and 100% of the arm in children, and that the width of the bladder is 20% greater than the diameter of the arm. If the cuff is too small, the reading will be erroneously high. If the cuff is too large, it will be erroneously low. If in doubt as to whether the cuff is large enough, use the next larger size. Cuff application. Apply the cuff to the patient's bare upper arm with the middle of the cuff at the midpoint of the sternum and center of the bladder directly above the brachial artery. To determine the center of the bladder, find the two ends of the bladder inside the cuff and fold in half. The halfway point marks the center. Do not rely on the site where the tubing attaches to the bladder to be the center. The lower edge of the cuff should be at least 1 inch above the bend in the elbow. Wrap the cuff smoothly and snugly around the arm. If the cuff is too loose, the pressure determination will be inaccurately high. If using a mercury manometer when applying the cuff, disconnect the rubber tubing that connects the cuff to the mercury manometer to reduce the possibility of bumping the manometer or knocking it off the table. Ensure the patient is not leaning on the tubing or on their arm. Be certain the mercury column is vertical and that the mercury or aneroid gauge can be read at eye level. Patients can hold the aneroid at the screener's eye level with the other hand. After rapid inflation of the cuff, perform a rapid deflation of the cuff to determine a preliminary estimate of systolic blood pressure. Knowing where the systolic blood pressure is will determine the necessary cuff pressure to begin your measurement. This technique is used because of the occasional presence of what's called an auscultatory gap that exists primarily in people with high blood pressure. An auscultatory gap is a condition in which the first blood pressure sounds fade or disappear completely during deflation and then reappear at a level well above the diastolic pressure. If the screener measures blood pressure without first performing an estimate of the systolic pressure, Their choice of the level to which to inflate the cuff is based on guesswork and may underestimate the true reading. For example, if the patient's true blood pressure is 210/90 with an auscultatory gap between 180 and 144, and the pressure in the cuff is raised to only 160 or 170, the systolic pressure will be recorded at the incorrectly low level of 144 millimeters of mercury. The screener can cause an auscultatory gap by inflating the cuff too slowly. To prevent this, inflation should always be done as rapidly as possible, and deflation should occur at a rate of 2 millimeters per second. A preliminary estimate is also necessary to provide comfort for the patient. For example, for a patient whose blood pressure is 106/70, it will only be necessary to inflate the cuff to 136 millimeters of mercury rather than to 160 or 180. Discomfort alone can artificially inflate blood pressure readings. This technique is also more comfortable for the screener, who will not have to inflate the cuff to such a high level on every patient. This reduction in repetitive motion can help prevent conditions such as carpal tunnel syndrome in screeners who often check blood pressures. Wait for 15 to 30 seconds between cuff inflations. Ensure the mercury level has returned to zero by squeezing the cuff to release all air or by briefly disconnecting the cuff from the manometer. With a manual cuff, the needle must return to zero. Palpate the brachial pulse. Stethoscope placement. Place the stethoscope diaphragm, the larger flat side of the stethoscope, over the brachial artery just below, but not touching the cuff or tubing. The bell may also be used for auscultatory readings. If the stethoscope is in contact with the cuff or tubing, this can cause sounds other than the sounds of the blood pressure to be heard and can lead to faulty readings. Inflation. Inflate the cuff 20 to 30 millimeters above the level where the radial pulse disappeared. This is the maximum inflation level. Deflation. Open the valve to begin deflation. Maintain a constant deflation rate of 2 millimeters per second. If deflation occurs too rapidly, the reading obtained will be inaccurate, usually too low. Never allow the mercury or aneroid needle to stop during deflation. Once the mercury or aneroid needle begins to fall, never pump the cuff higher without completely deflating the cuff. Both situations cause venous congestion and result in erroneously higher readings. Auscultation. Listen for the carot cough sounds. These are the audible noises used to measure blood pressure. Record the systolic as the first of 2 consecutive sounds to avoid identifying a single stray sound as the systolic. Stray sounds can be caused by the stethoscope picking up other sounds in the room, by rubbing the stethoscope against the skin, etc. Record the diastolic at the point where all sounds disappear. This is 2 points below the last sound heard. When the sounds have disappeared, continue to deflate at 2 to 3 millimeters a second for another 10 millimeters. If no further sounds are heard, rapidly release all air from the cuff and record the blood pressure. If other sounds are heard and then the sounds disappear again, record this last disappearance as the diastolic pressure. This is done because an auscultatory gap can also be present at the diastolic level. Failure to continue listening for another 10 millimeters can result in recording an artificially high diastolic blood pressure. First visit. At the patient's first visit, record blood pressure in both arms. If the blood pressure is elevated at 120/80 or higher, wait 1 to 2 minutes and take a second reading on the other arm. If the 2 readings differ by more than 5 millimeters mercury, wait 5 minutes and take a third reading in whichever arm had the higher pressure. If the patient takes blood pressure medication, note the time the medication was taken before measurement. Blood pressure reporting. Average 2 or more systolic and diastolic readings. The average reading should be used to determine the state of blood pressure, pre-hypertension, stage 1, or stage 2 high blood pressure. Provide the patient's blood pressure measurements verbally and in writing. Troubleshooting. Problem number 1. The cuff extends below the bend in the elbow. If the bottom edge of the cuff extends below the bend in the elbow, the artery will not be evenly compressed, leading to an inaccurate determination of the pressure levels. A true reading will be obtained if the cuff is applied to the lower arm and the radial pulse is used for both the preliminary estimate of the systolic level and to listen for the sounds of the blood pressure. Since the radial artery is smaller than the brachial, it may be more difficult to hear the blood pressure. Using the bell side of the stethoscope will help to amplify the sounds. The systolic pressure in the lower arm will be about the same, however the diastolic pressure may be a few points higher. Problem number 2, an absent fifth phase. The sounds of the blood pressure are divided into 5 phases. 1. Tapping, which is very faint at first. 2. Swishing. 3. Knocking. 4. Muffling. And 5. Silence. In some patients, sounds are heard down to 0, resulting in an absent fifth phase. This is normal in children and after vigorous exercise. It may also occur due to certain medical conditions, such as anemia, thyrotoxicosis, aortic regurgitation, or a hyperkinetic cardiovascular system, and thus should be reported to a physician. If an absent fifth phase is encountered, the screener should also check to ensure that faulty measurement technique is not the cause. Either improper cuff size or heavy pressure on the stethoscope can lead to this occurrence. When this does happen, the diastolic pressure should be recorded at the level at which the loud sounds of the knocking phase become muffled and at 0, for example, 162/74/0. Problem number 3, inability to hear the sounds. 3 methods can be used to enhance the loudness of the blood pressure sounds. 1. Inflate the cuff as quickly as possible. 2. After estimating the systolic pressure, raise the arm for several seconds, then inflate the cuff to the maximum inflation level. Lower the arm, place the stethoscope over the pulse point, and proceed with the blood pressure measurement. 3. Inflate the cuff to the maximum inflation level. Have the patient open and close their fist several times. Place the stethoscope in position and proceed with the measurement. Problem number 4, mercury spills. Recently, there's been much discussion regarding the EPA's regulation of devices containing mercury. However, the EPA has not banned the use of mercury blood pressure manometers. It has issued regulations controlling the emission of mercury from industrial and power plants and the disposal of mercury wastes. The EPA also agreed with the American Hospital Association to encourage member hospitals to limit their use of mercury products. Mercury manometers are preferred for measuring blood pressure because the screener can easily determine their accuracy through a simple visual inspection. However, aneroids are also acceptable if they are checked for accuracy regularly against a mercury instrument. This procedure requires a Y connector that can be purchased from most blood pressure equipment manufacturers and takes only a few minutes to perform. The actual procedure is included in the handouts for this course. In the event a mercury spill does occur, the following actions should be taken. Immediately ventilate the room. Put on goggles and gloves. Collect the mercury using a suction device and place it in a sealed container. Return the collected mercury to a facility that is licensed to dispose of it properly. Do not attempt to pick up mercury with bare hands. if mercury gets on the hands, they should immediately be washed with soap and water. Do not attempt to wipe up the mercury with a paper towel, wet or dry. Mercury will not adhere to the towel surface. It will continue to break up into smaller beads. Never attempt to vacuum up the mercury. The heat of the vacuum will vaporize the mercury and it will be inhaled. Do not allow mercury to come into contact with gold jewelry. It will strip off the gold. Do not dispose of mercury in the trash. It is a hazardous material and it's regulated. Do not pour into a sink or commode. It will remain there indefinitely. Mercury spill kits are available. They usually contain goggles, gloves, a suction device, a substance to spray on the mercury so the beads will cling together, a substance to spray the room to decrease the toxic vapors, and a container to place the mercury in. Tips and tricks. The recommendations I share with you are from my experience measuring and treating high blood pressure, as well as from the most recent blood pressure guidelines endorsed by many medical organizations, including the American College of Cardiology and the American Heart Association. It's been said that office blood pressure measurement detects high blood pressure. However, high blood pressure is diagnosed by self-measured blood pressure monitoring at home. There are two conditions to be aware of when taking blood pressure measurement in the office. Most people are familiar with white coat hypertension. This is where blood pressure is normal when measured at home, but elevated when the patient is in the office. These patients should be monitored more frequently as they are likely to develop high blood pressure with time. The other lesser-known condition is called masked hypertension. This is where blood pressure measurements in the office are normal, but home blood pressure measurements are elevated. It is estimated that masked hypertension occurs in 10% of adults with normal blood pressure measurements in the office. These individuals have the same poor outcomes as people with diagnosed high blood pressure. In my experience, many people have access to a home blood pressure monitor. However, this may not be the experience of those who live and serve in underserved areas. If I see blood pressures greater than 130/80 in my office, I encourage the patients to check their blood pressure at home, if possible, with the following advice. Use a validated, automated oscillometric device 2 times daily for 7 days. Ensure about 5 minutes of quiet rest before taking blood pressure measurements. Avoid smoking, caffeinated beverages, or exercise within 30 minutes of measuring blood pressure. Sit with back straight and supported, feet on the floor and legs uncrossed. Keep your arms supported on a table with the upper arm at heart level. Place the cuff above the elbow. Take 2 readings. The first one before taking medications in the morning, and the second one before dinner in the evening. Average the 2 readings. The bottom line is when blood pressure measurements are appropriately obtained in the office or at home, blood pressures consistently greater than 130/80 are consistent with the diagnosis of high blood pressure.